Voilà, c'est un plaisir, mesdames et messieurs, de vous voir nombreux pour faire plus ample connaissance avec un homme et un professionnel qui incarne la thématique de ce festival, les soins, le soin, care, puisqu'il est chirurgien, cardiaque, pédiatrique, et que dans son livre intitulé
And in his book entitled Et au centre bat le cœur and at the center beats the heart, you discover the man and the questions that he wonders about. This book, Et au centre bat le cœur, was published in 2016. It was republished in paperback by Artaud in 2018 with an additional chapter. I think there were 18 chapters at first, and there's one additional chapter in the 2018 edition. Rene Prêtre, I think you need no introduction. For many people in Switzerland and abroad, you are the Swiss Citizen of the year 2009. So this book, Et au centre bat le cœur, comprises 19 chapters. So we'll come back to this one last chapter. You drafted it on the basis of reports you would dictate on your voice recorder after the surgery you had performed, because you realized that what you had experienced was a very strong experience. You wanted to document it. Then you added more personal, more intimate thoughts, taking a step back, thinking about what you did. So there are these two parallel lines in all the chapters of your book, and it's extremely visible. Some of these thoughts are printed in italics, but were these intimate thoughts the hardest part to write or not? Well, it's hard to say what was the hardest part to write. There were a certain number of cases that I thought were very striking. At the time I was in Zurich, I had dictated in French because it's my native language, and I wanted to dictate these stories on cassette. I send them to my secretary in Geneva, and she typed them up. You have this idea, you want to do it, it doesn't necessarily happen. And in 2010, when I became a Swiss Citizen of the Year, there was a lot of media attention on me, and 5 publishers came to tell me and say, well, we'd like to write a book about you. We will give you a ghostwriter who will write the book instead of you. I gave journalists a certain number of interviews, and I realized that the answers, the questions were not the questions that I wanted to answer. The answers were not quite right, and it was always a little complicated for me. Interviews you tend to forget, but for a book, I didn't want that to happen. They would tell me, well, it doesn't matter if you don't like it, we'll just stop and start over. But that's not necessarily the way things happen. This is why I wrote quite a few scientific articles. I would write editorials where I wrote my ideas. I know how to write. I'm certainly not an author, a literary author, but I can tell a story from beginning to the end with a scientific demonstration. So if people want me to write, if people are ready to publish me, at least I won't have a hard time finding a publisher, and that's when I started writing. I was working alongside, so it took me 4 to 5 years instead of the year that I thought it would take me. And my work is quite specific. I'd say that the stakes are extremely high. I operate on the heart. The heart is the organ of life. If the heart stops, if the heart has a problem, it's the life that stops. And I'm not operating on people who are 60, 70, 80 years old who are looking back on their lives. These are children who have their life in front of them, so the stakes are huge. It's the case of pediatricians who have to face meningitis, for instance. But they don't face meningitis cases every day, whereas I operate on the heart every day. So the stakes are huge. These are children, they've got 60 or 70 years to go, and I was very much afraid. I've had my disappointments, great experiences. It's dizzying, and I didn't want to give all the answers. At first, I'd written something that was not very personal, and I gave it to read to someone who said, that's not what people want to know. People want to know how come you, growing up on a farm, ended up as one of the greatest heart surgeons. So I took the book again. I didn't want to start with your run-of-the-mill autobiography. So I started with the first chapter. I'm in New York. Someone's been stabbed. You need to operate very fast. I don't know whether you remember Tintin. When you read, all of a sudden you saw a gun, and then you had to wait for a week to see the rest of the story, and then you realize it was a water gun and not a real gun. And this guy in New York told me, I feel like I'm dying. It's nothing rational, but there you say that there could be something behind it. And I stopped there and started on the biography part of the story. So I liked having chapters with both aspects. The facts on the one hand combined with my personal reflections, and I like to build it as a thriller and give the readers the solution right at the end. So it was quite a lot of work for me. Yes, quite a lot of work. So on the one hand, we see you in the operating room. There are lots of very technical descriptions. You try to be as pedagogical as possible for the layman who has no idea of the anatomy of the machines. But you operate on the heart, and we know what's happening in your mind. You're there, you're spending 7 to 8 hours in the operating room. And for us to understand how you approach the stress, the split-second decisions, the successes, the failures, because there have been some, and I would like to come back to page 47 of your book, where you say, I also glimpsed the treacherous and terrible danger for a surgeon when his arrogance, high on success, transports him too high, so high that he no longer feels the attraction of fundamental laws, so high that he starts believing he's above them, so high that he starts to believe he's infallible. This feeling of almightiness, have you felt it, Rene Prêtre? Well, I think I've always been honest enough not to get there, but I did see people whom it happened to. They started doing things that were absolutely not reasonable. It can fly a couple of times, but that's it. Just like with many things, there's a great deal of strategy, of technical details. You've got a checklist. We've all been in a plane, and we've always seen air hostesses reminding us of security rules. Fine. You drive fast down the road, a couple of bends, it's okay, you manage, but sometimes there's a bit of oil on the road and you have an accident. So I've seen people thinking, not that they were infallible, not that they were God, but who were no longer down to earth. All of a sudden, a problem occurs. And I've seen this happen a couple of times. Now, I don't mean to say I always played by the rules, but I was always extremely careful. I tried being as humble as possible in the work that I carried out, and I tried to be as respectful as possible vis-à-vis the children that I operated and their parents and their entire family. This quote
du personnel et des
shows
techniques du professionnel
that
dans votre livre, il arrive au milieu d'une opération
personal aspects, the technical aspects in your story, and I'd like to come to the story of a child who is affected by the tetralogy of Fallot. Can you describe this disease? Well, this disease happens when the heart is separated into two. That's what happened over the course of evolution. Part of the blood goes into the lungs, part of the blood goes into the body. Blue blood comes back to the heart because it's poor in oxygen. Red blood is the one that has just been oxygenated. If all the blood goes into the lungs, the entire heart or the entire blood is red. But sometimes there's a congenital heart defect, which means that the blood is mixed, and the less there is oxygen in the lungs, the bluer the blood. These children were called blue babies. They were also called Smurfs, but they are also the ones who helped heart surgery develop. In the 50s, we were unable to operate on the heart, and these children would die when they were 15 to 20. We saw them die very gradually. They didn't have a future. It was heartbreaking. We all were trying to find a solution for these children. And that's when the first heart surgeries occurred. Of course, there were many problems at first, but it's with pediatric heart surgery, especially these blue children, that heart surgery developed. You speak about heart diseases, hearts on the right-hand side of the chest. Yes, that happens once in a while. It's nature. I can't really explain it, but sometimes we've got mirror images. The liver is on the left, the heart is on the right, the stomach is on the opposite side. It's rare, but it happens. I think 5% of all our surgery, we do quite a lot of operations, 450 pediatric operations per year. We do a lot more here because we've got many children coming from Africa, but in Switzerland it's about 450 operations per year, and 2 to 3% for this reason, so 8 times a year. But it's sometimes very disturbing because all of a sudden you've got to go on the other side, and I've seen this in Cambodia 3 years ago. We had 3 cases of children who were left for me. They were put aside for me. All of a sudden there were a lot, and I thought it was a lot, and they said, no, we put them aside for you, and you really have to concentrate to know what is front, what is back, what is left side, what is left, what is right. On a normal heart, I know exactly where the vessels are, and I manage without any problem, whereas in these particular cases, it's as if I were driving in the UK backwards, and I had to take a roundabout. So you really have to concentrate to make sure you get it the right way. Another example of anomalies of nature is the story of these children with the wall between the 2 heart chambers. Yes, normally, once we, humankind, living beings came out of the water. That the heart is always there. Oxygen is fundamental in the way the body works, but oxygen is a molecule that amounts to 20% of the air we breathe. It has to be able to get into the blood, and the only way this can occur is to have a membrane that's very thin. This is why our lungs are dry, but they're bathed in blood. Lungs are right next to the heart. You don't need very much pressure. And with low pressures, you can have thin membranes. This is why batracians only have one ventricle. But once we started standing, we needed to have greater blood pressure. We've got 120, 130 blood pressure, whereas it's only 20 or 30 in the heart. Progressively, nature has separated these ventricles. One has high pressure, the other one has low pressure. If there's a hole, it's the highest pressure that'll go to the low pressure side. If pressure was equal on both sides, it wouldn't be a problem. And I think that's also why the heart, instead of being in the center of the body, it went to the left. There are a certain number of organs that are not symmetrical, whereas the heart is symmetrical. But because there's this difference in pressure, the heart went to the left of the body. It has nothing to do with politics. It has to do with blood pressure. You have been operating on hearts for the past 30 years or so, Rene Prêtre. Can these things be screened before birth? And you know that you can operate at birth? Yes, of course, there can be antenatal screening, but not at the time. I remember my grandmother telling us that my aunt had a son who died 4 or 5 days after birth. It happened very frequently before heart surgery happened or developed, before antenatal screening occurred. I know exactly what can happen in such cases. Nowadays, there is antenatal screening, especially for severe diseases. Minor diseases can be missed, but they aren't usually fatal. And what we operate, 15–20% of our operations occur in the week or two after birth. Otherwise, these children would die. If we looked at statistics, it was 90% of mortality within the 2 first weeks. There's another peak between 3 and 6 or 8 months, where 60 or 70% of our volume occurs, and then the rest is anywhere between 4 or 5 years. This has been changed by antenatal screening. I've seen my last patients the day before last. I'm going to leave. I can no longer have new patients. But I had to keep 4 or 5 spots for coming pregnancies. What's the difference between minor disease and severe disease? Well, if you've got a tiny little hole in your heart, like ventricles, they're of the same size. You do an ultrasound, you see that the size is right, you can miss something. A child during pregnancy, if he has his back to you, you can't really see what you want. Sometimes you're lucky enough, you can see it because he's just turned. But you can't always see everything with an ultrasound. When a ventricle is much bigger than the other, that you can spot, and there you can see that there's something that's abnormal. And these children need to be operated on immediately. A hole in the heart is usually operated on anywhere between 3 to 6 months. This is something that we usually see fairly fast. These children don't gain weight enough. You can hear a murmur, and you can repair this without any problem. But severe diseases with vessel inversion, this is something that we can screen before birth. 80 to 90% of all cases are screened before birth. We spoke about technical aspects of your work, but there's also the encounters and the operations that you've carried out. Today is May 14th, and I don't necessarily want to campaign for organ donation, but there is this chapter in your book called Night Flight. A lot of your chapters refer to books that have had a huge influence on you. If you want to give arguments in favor of organ donations, what would be the argument? Well, we speak about consent, be it explicit or implicit. Currently, it has to be explicit. You carry a card in which you say, if I die, I want to donate my organs. Yes, tomorrow there is the vote on organ donation. But if people don't say anything, then the situation isn't clear, and we usually ask the family what they think about it. It's always the same. I've experienced it. You've got 3, 4 siblings. You ask them, and they're not sure because they've been estranged for a certain amount of time. They look at each other. One says, well, I'm not sure what he would have wanted, and they usually end up saying no. They don't want to take any chances. They're not quite sure what their brother or sister's dying wish was, so they say no. In 40 or 50% of all cases, people end up saying no, which is quite high. Now, when we ask for organs, it's following the sudden death of someone who is fairly young and never beyond 60. It's usually an unexpected death. It's never due to terminal stage cancer. It's a shock for the family. They weren't prepared. And when it's a child, the family's entire world is shattered. They're in the darkest place possible. They've just lost their child. It's probably the greatest pain that anyone can experience on earth. And we know we've got children waiting for an organ transplant. We ask the family, and I'm quite surprised because we only end up having 30% of no's. Why? Well, because families say, my child liked other children. If he were alive, he would say, yes, we know that the heart of our child will continue beating in someone else's body. It's a kind of solace, in a sense. They look at their child, think, he was generous, we should be generous. So this is where we are at. In the adult world, people are more pragmatic, people are less certain, and they'd rather say no. With implicit consent, we just assume everybody would agree, except if they've explicitly said no. In this particular case, it's no longer the family's responsibility to betray the dead person's dying wishes. But the benefit of the doubt would be in favor of organ donation. Now, there are countries like Spain who already have this mechanism, but you do have to realize that if we don't have enough donors compared to the 90s, I started organ transplants in the 90s, we had many more hearts at our disposal, but there were many more road accidents. You could drive much faster. There were much fewer checks and controls. We've also progressed in people have less high blood pressure, so there is progress. We've got fewer donors, but there will still be people dying suddenly for many different reasons. There are accidents, there are suicides, there are cases of meningitis. And in these cases, we think that if we had more organ donations, it would be great. So let's come back to the chapter entitled Vol de nuit, night flight. You explain how you were on holiday in Zermatt. Someone calls you up in the middle of the night, and you are told there may be a heart for Michael, and there starts a race against time. I found this chapter extremely interesting because reading you, we realized that there's a huge amount of self-control, but you're under huge time pressure in this particular instance. Yes, night flight. I get the feeling that organ transplants or heart transplants always occur at night. It's always during the night that they call you up. Organizing an organ transplant is really complicated. It takes quite a lot of time. When they tell me, well, there's an opportunity, we've got a heart at our disposal, I know that there are only 4 hours. You have to send the teams, get the organs where the donor is. The donor can't be moved, so you've got to wait for these teams. We don't, for children, we don't have much demand. We don't have many donors. You've got to take weight into account. For adults, it always happens in Switzerland. It's limited to Switzerland, whereas for children, it's all over Europe. This is why I wrote Night Flight. We go by plane to get these organs. It would take too much time by ambulance. Well, can you describe what happens next? Well, things have changed quite a lot. In the 30 years I've carried out heart transplants, operations have become very complicated. Half of our patients and children wait for a heart transplant. They have an artificial heart pump that replaces the heart that is too exhausted, and that way we can wait for the right heart. We're no longer in situations where people are dying. We've got machines that can give them an extra 10 days reprieve, and that's it. Now we've got these artificial hearts that help us wait for the right heart. At the time, we would just use the heart that we were offered. If you had the heart of a 60-kilo man and had to be transplanted, a 90-kilo man could lead to problems. Now there blood thinners, dissection. It takes at least 2 hours to prepare. So you need to coordinate with the team. Currently, despite the fact that there are ultrasounds, we know exactly how the heart works. My team goes there. They go to, say, Naples. They open the chest, see whether the heart is suitable, and then they give me the okay. The child is either in Lausanne or in Zurich, still already in the operating room. Then they are put to sleep for the operation. We know how long it'll take for the heart to get to us by plane, and we start the operation on this basis. You take the heart out, see how things are, and sometimes I take the heart out half an hour before the new heart comes. It used to be that you would wait for the new heart to come before you started operating, but because it takes so much time, there's 3 hours during the entire trip, the heart no longer receives any oxygen. It's on a bed of ice, and that's when you take out the heart of the donor, that's when the 3-hour countdown starts. I need an hour and a half to take out the new heart. If I were to wait, the new heart would never start. So it's a point of no return. At the time, people used to say, well, if there's a plane crash, what do you do? But plane crashes are fortunately very rare. If I carry out surgery that requires 4 or 5 hours during which the heart is stopped, I can inject blood in the body. It's like at the swimming pool, you're underwater, and you can go back to the surface of the water, and then you dive again. And then you go back up, breathe in, and then you go down again. That's exactly what we do during surgery, every 20 minutes. So we can operate for 4 hours. With a heart transplant, you go down, and for 3 hours, the heart is underwater until it goes back up to the surface to breathe in. And if it takes too long, the heart does not start again. That's why timing is of the essence. Under 3 hours, everything's fine. 3 hours and a half or more, that's when problems occur. And once you open the clamp, the heart starts reacting. It's really frightful, because that's when you know whether you win or you lose. You can always say, well, you shouldn't be taking hearts that come from too far away. Fine, why not? But the problem is that even with children, I've lost 5 children because we waited too long. Even the machines that we have can lead to a blood clot, a stroke. We've had problems like these in the past, and each and every time we'd waited for 10 months. We say we should transplant 4 months after starting to use an artificial heart. But when you don't have a heart at your disposal, you need to wait. Right now, I've got a child who's 30 months old. We've been waiting for the past 5 months. We're still waiting. Now, if I've got an opportunity, and it's a huge dilemma. If I wait for too long and the child dies, it'll be a failure. It'll be a defeat. If the heart comes from too far away, I don't know what the right solution is.
You have to take a risk. I know you have to take as few risks as possible, but in actual fact, you always have to take a risk. And once you've taken the risk, there's a lot of anxiety, because you have to wait and see if your choice is the right one, and you hope you assess the situation properly. Let's talk about the figures for failure. You say when you lose a child, it's very rare. You said about 2%, is that right? Yes, mortality, but that's not the only kind of failure. But that's a tangible figure, dead or alive. You can't really fake that. Now, are people happy with the operation? That's very much more subjective. But scientists like what's clear-cut. So mortality is always a parameter for us. It's to know whether a unit is working well or not. So globally, the good units are at 2.5% to 3.5%. Even lower if you're lucky. So out of 300 cases in the year, we have about 6 cases like that, but it's not something that we worry about every day. The risk is still quite high. But these are also cases that have no chance of surviving without us. So that helps with the idea of being defeated. And we have to look at it optimistically. They wouldn't have had any chance at all if we hadn't intervened. How do you talk to the parents? Because you talk about the infinite gratitude that parents express with photos of their children when they've grown up, who are flourishing. So what happens when you lose a child? How do you face them? Well, once again, it depends on the circumstances. If the diagnosis is very poor, if the child is the child's condition is deteriorating hour after hour, of course it's still a shock for them. You have to support them, but if I've done my work correctly, I mean, there could also be a problem with the lungs. Sometimes the heart will start beating, but the lungs will collapse. So this is above and beyond what you can control in the current state of medicine. But although you don't feel that you've failed, you still have to face the parents' grief. If an operation has gone smoothly, mortality is never at 0. But as I said, 2 to 3%, and you lose a case, you lose a patient, that's very difficult because that means you assess the situation incorrectly at some point, and then you are responsible to a certain extent, and then you feel, well, maybe not guilty, but responsible. I strive for perfection, and I'm always very upset if I have to go through this experience again. And you have to you manage your own feelings as well. And I have to admit that it's very difficult for me too. What I do as a routine measure when there's failure, well, it's difficult to talk to parents who are completely plunged in their grief. They might say yes. They might, and I call them into my office a couple of months later, and I discuss the accident with them for an hour or two to see if they have any questions. And then, of course, it depends on the parents, but I try to restore their trust in themselves, their confidence in themselves. It's always very difficult when you have a child with a malformation and you feel responsible for that, but we know there are factors that are beyond the parents' control. The rest is the roll of the dice of genetics. So we want to help them not feel guilty about that, about their choices, because often we guide them in making these choices. And if they're young, I often say, listen, your risk is slightly higher than in the general population, but it's not that high, 2 to 3 times higher than the 0.8% for the general population. So their risk would be 2.5 to 3% of congenital malformations. So you still have a very good chances of things going well. Some families have 3 healthy children and the 4th has a malformation. So I try to reassure them. And sometimes I get a letter saying, Mr. Prêtre, we wanted you to know that we had a little boy or a little girl, and we're extremely happy, and that makes me very happy as well. You mentioned in your book Robin, these are all, you've changed the names of these patients. Well, some of them are recognizable. There's a child that got stepped on by a horse. I only seen it twice in my career, so of course the family recognized their child. And then there's little Lucy. Perhaps you could talk a little bit about those 2 cases. Well, Lucy was one of the patients who touched me the most, I think. I can't remember. I think she was 12 or 13. She was a teenager. She had cancer. Maybe that makes children grow up faster. These children who have to face death at such a young age, sometimes they're worried about turning off the light in the evening because they're worried they're not going to wake up in the morning. But still, their maturity is greater than that of other children their age. She had a child's face, but her mind was very mature. The questions she asked were very difficult because you want to guide, I wanted to guide her through this difficult experience, but she could tell that her life was in jeopardy. Her mother was not very vocal, and I said, it's easy for me to explain the diagnosis and the solution. But her questions were very difficult. Am I going to survive? So it's very difficult to talk to a teenager. I'm not an oncologist, and her tumor was right on the heart, and we had to take it out because it could cause heart to failure. She had no eyebrows. She'd already been through chemotherapy. So I found it difficult to talk to her, and I evaded the questions by saying, we're going to do everything we can to make sure that you come through this. And she was so brave. We operated on her. I don't know how many hours it took us to take the tumor out. I wanted to try to save the lung because the lung was caught up in it, and I had to reconstruct all of the vessels. It was like embroidery. I could have taken the lung out, but her quality of life would have been very good. It would be much easier for me, of course, but the consequences would have been quite dire. And she recuperated very fast. That's always I go out. I usually go in to see the patients 2 or 3 days, 2 or 3 times a day, and but I was really busy, and by the time I got to see her, she'd already gone home. And then I lost sight of her. She lived near St. Gallen, and she was in contact with the oncologists, and I remember one of them came and said, Lucy has metastases in the brain. She's been hospitalized. She's in a coma, and she died quite soon after that. And when my colleague announced that, it was if somebody, my legs, somebody had swept my legs out from under me. I couldn't process the information. That was a difficult moment for me. We'd done everything we could. Unfortunately, there are several pathologies that we're still powerless to cure. And it reminded me of the poem by Goethe, the King of Elms, who rides at night. And we didn't see her that way. We thought she was going to survive. And that was just her fate. I don't want to give away any secrets, but you said earlier that you have a backache. So let's talk about that aspect of your work. We've had some very difficult cases lately. It's always on a Sunday. We had a young person who'd already had several operations. He had 3 major problems. The biggest one, I thought we were not going to be able to deal with the 2 others because I don't know how many hours we spent on him. I think we started at 6 p.m. and we ended at 2 in the morning or 4 in the morning. So I put him on a machine, and then we saw that a coronary artery was blocked. I was going to do a bypass, and that took us a lot of time as well. And then there was a valve that I hadn't dared to touch because I didn't want to take too much time for the second operation. 2 days later, I had to replace the valve. So in 7 days, 2 days, 7 days, there were 2 days, there were 7 operations, and his father was there. And I was, and we realized that the operations had lasted 22 hours in all. Sorry, there were 3 operations. Then a couple of weeks ago, We had a scheduled operation. Somebody was had bleeding from the lungs, and I had to work on the artery. When I ended the operation, I sent an SMS to journalists, and it was 1:30 in the morning. So I think that's why my back is hurting me. I'd like to come back to the more personal dimension. You grew up in Boncourt. You are a football fan and you play football. We could draw an analogy between the football team and your team in the operating theater. You were captain of your team. No, those were the best moments of my life. I loved playing football. We had a good team. We used to win a lot, and sometimes I was the hero. Sometimes we would lose, and it was my fault. I mean, it's all of that was part of the sport I loved. Having said that, there were different personalities. Not everybody was a team player. Some of them were self-centered or on an ego trip. And we can't allow ourselves that kind of attitude in the theater. So the analogy is both are groups of people who function together. I think we're more of a concert and ensemble. There has to be harmony. There may be one person who's better known than the others, but if the orchestra is not good, the other players are not good, it won't work. And a surgeon obviously has a central role. But the cardiologists have to make the right diagnosis. We have the anesthesiologists. We have those who are in charge of instruments. It's all a choreography, and it has to be harmonious. It's like a dance. If you want it to be smooth and elegant, there can't be any abrupt movements or incidents. Then there's the person who operates the heart-lung machine. All of it has to be harmonious. Yes, a lot about training. We heard, seen in the media that you're planning to retire. You're not going to be the head of the clinic, no, head of the department. Not the whole clinic, no. I'm not interested in the administration. But in Zurich and in Lausanne, they understand that because when you're a professor, you're supposed to get commissions, there's supposed administrative work, and I'm most effective in the operating theater, and I managed to avoid that. But you're interested in training surgeons? Yes, obviously. In pediatric surgery, however, I don't train a lot of surgeons because I don't need to train the whole team. Pediatric, we've got, for every pediatric surgeon, we have 4 that will be working on adults. And why is that? Well, a good surgeon is not only has to be a magician with his fingers, he also has to have a good tactics. The sequence of the operation is so important. So that involves a lot of knowledge, experience, a lot of reading, exchanges with others, intelligence, instinct. Some people feel things better than others. So I think you have to be a good tactician, you have to be a good technician. In pediatrics, where there's a more reconstruction, for adults it's more replacement of valves. If the person is 70 years old, you can use a pig valve. It's no problem. However, if you've got a retracted valve and you have a problem of closure, that's very different. It's more like sculpture. So I think that people who have an artistic bent do better than those who want everything to be at right angles. I've never seen a right angle in nature, in the animal or vegetable kingdom. In minerals, maybe, but everything else is based on curves. Let's end with your humanitarian work. Le Petit Cœur is the name of your foundation. Perhaps you could say a word about Cambodia and Mozambique. That's where you spend most of your time. Are you going to be traveling more now? Yes, for 2 years, as you know, we weren't able to travel, just like everybody else, and I was very happy. I wouldn't say that they don't need us anymore in Cambodia, but they've become autonomous. In 2019, we inaugurated an operating theater. They have 3 or 4 cases that they operate on every day, almost as many as us. And we opened the center in Phnom Penh because the center in Siem Reap it's in the temple city, and they're now training their own surgeons, and they have 7 in total. And in Mozambique last year, they did 111 operations. They deal with a lot of cases that come in, and I continue to pay for the equipment and help them in other ways. And we also went out to launch a campaign with Les Couleurs de Cœur, which is a foundation in Geneva, which we have supported financially. And for the prevention campaign on a disease that attacks the heart valves if it continues for too long. So we want to prevent it, to diagnose it in children so that we don't have adults with cardiac problems. This is rheumatic fever. We don't have a lot of cases in our country. Pediatricians pay a lot of attention to streptococcal infections, and we give antibiotics, and that helps. So you're going to have a very active retirement. Thank you very much. I think we should take some time now for questions, and because I'm sure that many people in the audience have questions. Yes, sir. You have a question?
Merci beaucoup, professeur.
Thank you very much, Professor.
Merci beaucoup, professeur, pour ce que vous apportez.
Thank you for
notamment pendant tout votre travail, ce que vous
your
avez
work.
aujourd'hui. Ça fait
Thank
très
you for your talk today.
de vous entendre.
It's a great pleasure to listen to you and to meet you.
Il y a une cinquantaine d'années,
About 50 years ago,
professeur Rene et quelques autres
Professor
éminents
and other eminent
biologie avaient créé ou avaient essayé de créer le cœur artificiel.
created or tried to create an artificial heart. It didn't work, or it didn't evolve sufficiently. Where are we with that today? Yes, I remember. That was in Sion, in Switzerland. They were working in that area. It was quite ingenious, but the artificial heart is an idea that rose in the 1970s. The first one was implanted in 1982. Professor Barnard, you will have heard of. That was 1967, the first heart transplant. I always laugh when everybody knows Barnard, but nobody knows who transplanted the first kidney or the first lung. So Starzl was the first to transplant a liver. I've got all the answers now, but anyway. The heart is such a charismatic organ. We scientists see it as a pump, and an artificial heart is just a pump, so engineers can produce it, but we all know that there's an extra dimension. The heart is love, the heart is life. It's precious. When you transplant a heart, you feel like you're transplanting life. So the heart as an organ has great, evokes great interest in the media. Recently, they transplanted a pig heart in January. They could have done this with the kidney, but of course they chose a heart because they knew that they'd get media attention throughout the world. And the artificial heart came back in the 1980s. The problem is that our heart is an extraordinary machine that it's almost impossible to reproduce. They were complicated machines, but if they broke down for 4 to 5 minutes, the patients would die, and that's what happened. They would die one after the other. But progress was made because at the beginning of the 1980s, you would extract the heart and put in a machine, connect them to a machine. The machine would break down, the patient would die. So then in the 1990s, 3 major breakthroughs. We said, well, people who have a problem, 2 liters per minute instead of 4 liters per minute. If you're only doing 2 liters per minute, you're just lying down, you can't do anything. Why couldn't we have a parallel system, we thought, that would produce 3 to 3.5 liters? And then that seems elementary, but it was like Columbus's egg. And now we hardly ever replace the heart, we assist it. We put in a parallel system. In children, it's too big to put it inside the body. You can see this blood flowing out and flowing back in, and you can see a clot. You can see a clot, and that has to be dealt with. We stop the machine and we see that pressure declines, and we can do the repairs. But before, this was not possible. So just that was a huge change. And after that, as I said, we have a high-pressure side of the heart and a low-pressure side. And the high-pressure side is always the problematic one. The aortic and mitral valve, and it's often that ventricle that breaks down. So instead of putting a system on both sides, we put it on one side. In 85% today, we only have to assist the left ventricle. The other is usually okay. And that does away with 50% of mechanical heart failure, etc. Then I would say that at the beginning we wanted to imitate nature and have a system that compressed blood, like the heart, with pulsatile arterial pressure at 120. Have you ever seen a propeller when a boat is taken out of the water? It's small compared to the size of the boat. So if we have a small pump the size of a golf ball, we can pump enough blood for the heart. And the system 5,000 RPMs does not destroy the blood, and we can implant it inside the body. There's just a wire to transmit the energy. And this has changed everything for us. So we often use this system while people are waiting for a heart, or we use destination therapy, people who can't hope for a transplant but who could still live for a while. We've had people living with the system for 3 or 4 years, and we thought, well, they're 75, they can't hope for a transplant, but why not use this system? And that's the transition that's now taking place. So 5 or 6 years ago, when the French produced Karma, you will have heard of this heart. This is another system where you have to take the heart out and implant the system. It's better than the 1980s, what we had in the 1980s, but I'm wondering a bit about this because the other approach has had a lot of influence because the results are very good. It might be a niche market. When you can't assist the heart, you can replace it with this, but it's only that's only 1 to 2% of all our cases. So to come back to your question, yes, there was a pioneer group with Mr. Charles Hahn who did this research. A lot of surgeons were working on an artificial heart. We knew that transplantation was going to be important, but we didn't know if we'd have enough hearts to do it. And we thought perhaps we could develop a machine that would do this, but our heart is so effective. A competition cyclist increases his blood volume by heart output by 5 times, a factor of 5, 25 liters per minute. That's not something you can reproduce with a machine. Even when you introduce mechanical valves, you know that it goes up, it's okay to up to a blood pressure of 180, but otherwise, if you might have a heart rate of 250, and then the mechanical valves will not work.
If there are no other questions, it may be the end, the concluding message. Heart is a well-oiled machine. We are waiting for you upstairs to get your books signed. Well, I've written another book that's not been published. When I went on mission, I made a website for our foundation. It's a small foundation. There were only 3 of us. There was no administration, no overheads. We didn't really have the financial resources. Then with the Swiss Citizen of the Year award, I received funds. We were able to fund the Cambodia project, etc. When we built the website, we thought, well, okay, fine, but do a blog. I said, I don't have time, but I took my voice recorder, and between 2 surgeries, I would record a report, I would send it to Zurich, it would be typed, sent to me, and then I published it on the website. Or she published it on the website. And with the time difference with Cambodia, I'd see it around midday, and I'd see all the colleagues look at what I posted. And last year, the past 2 years, there was nothing that we could do. We were stuck here. It was a shame. So what I did was that I looked at all the blog posts, put them all together. I added pictures. We always took pictures with our iPhones. The CHUV wanted to publish it. It's about 220 pages. It's just a book that was written on the fly. It's not necessarily been proofread, so it's not perfect. I've got a couple of copies with me. If you're interested, I've got some copies in the car. Okay, thank you, Rene Prêtre. Thank you.